Okay, so when we left off on Friday, I remember I said you had to know tidal volume is the amount of air in 1 minute time moved in mils. So you have to know what it's measured in. And then minute volume is the amount of air they move in 1 minute. Tidal volume was 5 mils per pound. And then minute volume is your tidal volume that you get times the respiratory rate. And then residual volume you don't have to calculate, but that is the lungs never completely deflate when they exhale. There's always a little bit of volume left in the lungs. So every patient is going to have a residual volume, which is kind of what is left over. Now, the whole goal of inspiration and exhalation is to bring in oxygen and to carry CO2 out. And for the test, I also want you to know where the concentrations are higher and lower. So what this picture is depicting is what is happening at one alveolus. So if you remember, at the end of a bronchiole is an alveolar duct, and that alveolar duct goes to a group or a cluster of alveoli. Now, this picture is just showing what is happening this should be happening at every single alveolus. So, as an animal inhales, that oxygen that comes in is going to branch to all of those sacs. And every sac has a capillary, and that is where the gas exchange occurs. So what this is showing you that so the yellow is the alveolus. That's one of those air sacs. And so when an animal inhales, at the point of inhalation, and on the test, if I say what happens at inhalation, at the alveolus, exhalation, in the capillary during inhalation, at the capillary during exhalation. So there's the two phases. When an animal inhales, the higher concentration is inside the alveolus. So it has high oxygen and it has low CO2 because they should have already exhaled. So now they're inhaling again. It's high oxygen, low CO2. Now, the blood that's coming, remember, the blood in the capillary is coming to the alveolus. You can see the arrow. Well, obviously it's blue right now because it's high in carbon dioxide. This blood had just come from the body, from the right side of the heart, and is entering pulmonary circulation. So when the capillary comes to the alveolar capillary, when it comes to the alveolus, it is high in carbon dioxide, but it is low in oxygen, right? Now, as the capillary passes by, do you see how it goes from blue to red? Okay, now I'm going to explain what happens as it goes by the alveolus. This is gas exchange, so very important slide. What in the body, and I don't know, you maybe have not talked about it in chemistry yet, but there's something called the diffusion gradient. And in the body, things like to move from an area of high concentration to low. When it's crowded and it's higher in one, it wants to, and what's on the other side of it? Well, right now, the concentration of oxygen is high in the alveolus, but it's low in the blood. So by nature, oxygen wants to go from the alveolus to the capillary. Okay, so you can see oxygen goes to the capillary. Now, the opposite is in the capillary. Right now, the capillary is very high in carbon dioxide. And so carbon dioxide is like, well, I want to move into the alveolus because there's not a lot of carbon dioxide in there. That's why they switch. I call it tradesies. It's like, I'm going to go from high to low, and then the capillary is going to go from high to low. And that's how that gas diffuses. So the high level of oxygen diffuses to where the value is lower, which is the capillary. And then the high level of CO2 in the blood is going to diffuse into the alveolus because that's where it's lower. And they switch. So now when the blood goes past, you can see how now when the capillary leaves the alveolus, it is now high in oxygen but low in CO2 because it gave its carbon dioxide to the alveolus. So all they've done is switch spots. And when you go now during exhalation, wait, let me get my chat up here just in case. Okay. So now what's happened during exhalation or expiration, I like to call it exhalation, but what's happening now is during exhalation, the alveolus is high in CO2, and that CO2 is going to get exhaled. And now the capillary is high in oxygen and low in CO2. So you can see what I want you to understand, and if you have any questions, please ask me. What's happening is they've switched spots, and that's the diffusion. In the capillary, remember, this is internal respiration when they switch. Everything from the oxygen coming in to the alveolus is considered external respiration. It isn't until they exchange in the capillary that internal respiration occurs. Now, not that you have to know this fancy definition, but it says a total pressure of a mixture of gases is the sum of the pressures of each individual gas. I remember I read these rules in school and I'm like, gosh, what does this make sense to me? All it's telling you is that what we're talking about is gases dissolving into a liquid. The gas from the alveolus is diffusing into the blood. So the liquid is blood in this situation. So we're talking about blood, we're talking about gas moving from an air pocket, which is an alveolus, to the blood, and that diffusion gradient. So what is happening is the partial pressures of oxygen and CO2 in the blood is determined by the partial pressures of oxygen and CO2 in the air. There's a balance. So what we measure in the blood is influenced by what's in the alveolus. But the main thing is to understand how is it moving. Now, when this comes into play later in classes, when we talk about acid-base balance, okay, remember I said there is a balance between CO2 in the blood and the respiratory rate. So there is a measurement, and the other thing that we can do in anesthesia is we can do what's called a blood gas evaluation. We take an arterial sample of blood. You know, at Purdue we had little machines that we could measure it in the OR, or we could send it to our lab at the vet school. But I would take an arterial sample, and it would measure the percent or the pressure of oxygen and carbon dioxide in that sample. And by evaluating what is in the blood, we could kind of determine what was happening in the animal. It was another way to evaluate carbon dioxide and oxygen. Now, in surgery, we use a little monitor on their endotracheal tube, and it measures exhaled CO2. And then we have the little clip that goes on their tongue, and that measures oxygen. But those are both estimators. Both of those surgical monitors, anesthesia monitors, are just estimating oxygen and carbon dioxide. If we want to know the actual amount, we can take a sample, and we take it from the artery because arteries are oxygenated. You know, you can take it from a vein, but it's not as accurate. If you can hit an artery and remember I said when we talk about where do we draw blood from animals, you know, anytime you draw a basic blood sample for testing, you normally draw from a vein. But if we're evaluating oxygen and carbon dioxide, those samples are going to come from an artery because that is where we find oxygenated blood. So it's the pressure. So what we're saying is whatever's in the blood is kind of reflective of what is in the alveolus because there's a relationship of diffusion. Now, inside the brain, this is where we find the respiratory center, but this is what controls breathing. So inside the medulla oblongata, which is right, you know, when we talked about the brainstem, when we're talking about the base of the brain, remember I said the brainstem is right where it exits to the beginning of the spinal cord. So at the base of the skull and C1, your atlas, that protects this area of the brainstem. But what this does is this will it influences the rate of breathing, how many times we're breathing, and also how deep we are breathing. And every animal has a basic resting respiratory rate. Now, obviously, when you get them out of their cage and they're panting and they're excited or they're playing, that's different. But if they're at rest, they have what's called an intrinsic respiratory rate, which is like, what is their base respiration? Now, there are other control centers in the body that give feedback to the respiratory center. So there is kind of a feedback, because obviously there's times when we increase our respiratory rate or we slow down our respiratory rate or we don't breathe as deep. And I told you, you can control. What's interesting about breathing is that it is autonomic. It happens obviously automatically. You can influence, you can tell yourself to breathe fast, or you can tell yourself to hold your breath. But eventually the body is going to take that over and initiate a breath. So you can't do it. So where is the autonomic control of breathing come from? And this is where we get into mechanical and chemical components of breathing. So when we talk about mechanical, think about movement. That's the actual like inflating of the lungs and deflating of the lungs. That's actual mechanical movement. Now, you've heard me talk about stretch receptors before. Hopefully you remember this. On the surface or within the lungs, there are receptors that are linked to the brain, the nervous system, and they are monitoring the size of the lungs. So what happens is when an animal inhales, okay, and the lungs begin to expand, as they hit a certain point, there is going to be a stimulus detected by a stretch receptor. Think of it like an alarm. It's like the lungs get big, triggers, so there is a muscle contraction that produces that inspiration. But when the lung is detected to get to a certain size, it's going to trigger that stretch receptor and inhalate. You don't just keep going. I mean, you can only expand to a certain point. And then the stretch receptor is initiated. And then what's going to happen is inhalation is going to stop. The muscles are going to stop contracting. Then what's going to happen, it's going to trigger the muscles of exhalation. That's why it's important to know inhalation muscles and exhalation muscles. When the stretch receptor says you're too big, then the exhalation muscles, which are your internal intercostals and your abdominal muscles, they are triggered, and then the animal is going to exhale, and that's going to initiate those to deflate. Now, on the flip side, when the lungs compress to a certain size, there is a stretch receptor that detects that they're small. The size is decreased. It's going to trigger, and then inhalation is triggered. So as the lungs expand and contract, there are anything that gets big and small, stomach, bladder, intestine, lungs, they are monitored by these stretch receptors. And remember, receptor, and think nervous system. It's detecting the size, and that is also going to help dictate inhalation and exhalation. But what do we get? You should get a normal, rhythmic, resting, breathing rate. Now, think of how you inhale. You don't even think about how you breathe. You just breathe. But normally, if you watch me, I go. There was an inhale, short inhale, followed by a longer exhale, and then a pause. And then, okay, so inhalation should not be the same length as exhalation. Exhalation is longer. There's something, and we get into it when we get into anesthesia, but I'll type it here. There's something called the I-E ratio. So a normal IE ratio is inhalation. If I say 1 to 2 or 1 to 3, if that's like seconds, it would be like 1 second compared to 2 seconds, or 1 to 3, meaning I go. So there's inhalation, long pause. Now, What if I flip that ratio? What if I have a 3-to-1? That would be an animal that's going, which is like a gasping pattern. And that's a long inhalation compared to a short exhalation, which is an indicator of increased effort or respiratory difficulty. So a normal, you have to understand, and then sometimes animals have what's called a 1-to-1 ratio. That's what this is. If I was breathing like that, would you come check on me? If you saw me in the hallway going, nobody would check on me? Wow. Thank you, Rachel. Do you see what so understanding normal pattern of respiration, a normal regular respiration should be a short inhalation followed by a longer exhalation followed by a pause. And that is all set up by the brainstem and the stretch receptors. So that's what kind of sets this normal rhythmic resting rate. And again, if an animal is, doing a 3-to-1, well, let me see if I can, show a, okay, I'm going to show you a dog here. Now this dog, can you guys all see this video, I hope? I think it's important to watch this for a minute because so first of all, we all have our things we like to talk about. Respiratory system's one of my favorite, but also being an anesthesia teacher, and that's what I like. I'm trying to get you guys to understand, how do I look at a dog and know they're having trouble breathing? How do I know there's respiratory effort? This dog was in our kennel several terms ago before you guys. We got a batch of dogs from Animal Care and Control. They all broke with bad kennel cough. 2 or 3 of them developed pneumonia. It got bad enough, and this dog was probably the most severe. And when I went in the kennel, because the student said, Miss Landersky, you come check this dog, I could see, well, this dog was already on meds. It was just progressing. But I want you to watch, especially first of all, look at the face right now. It almost looks like there's a smile. And everyone goes, oh, dogs smile. Now, some dogs do smile. But smiling is an indicator of respiratory effort, a smiling appearance. Now, animals should breathe through their nose. So sometimes if an animal has, if they're congested, sometimes there's an increase in effort because they're trying to breathe through their nose. Now animals do pant and open their mouth, but if they were breathing, if they're sleeping, they're not going, they're going. So sometimes, this dog, you watch its nose, watch its face, but I also want you to watch its abdomen and the IE ratio. Now there's barking because obviously I'm in the kennel, so. But just go ahead and watch. So pulling those lips back. Blowing bubbles. We had nasal discharge. Now watch the belly. So it's like there's a lot more time spent during inhalation, smiling to breathe. Now, this dog also had, see if I can pull the PowerPoint back up. There we go. This dog also had, had some, it was febrile, was not eating. I went in there when I made that video. I went in there and the food was all crusty because obviously they fed it in the morning and then the food dries up. So I went and put some hot water on the food and I kind of mixed it up and I hand fed her and got her to eat. because smelling and eating, but she was laying down. So while I sat in there with her, she ate her breakfast, which was good. And she recovered. She did fine. But this was probably like, this was a couple days after she had come to the kennel. And like I said, I think we had like 6 dogs on Clavamox because they all broke with this upper respiratory infection. Now, kennel cough starts as an upper respiratory, but this dog progressed to a pneumonia, which then moves into, which can happen sometimes. Kennel cough can progress to a lower respiratory tract. But hopefully you can see in that video that pattern. More effort on inhalation, nasal discharge, smiling, sometimes flared nostrils. And that's why I talk about, you know, what a normal respiratory pattern should look like, what a normal timing. So now let me talk about what happens. There is a chemical component to breathing. Now, obviously, stretch receptors, muscles, nervous system, that's all mechanical. That's muscle control, chest expansion, lungs follow passively. But chemicals are being monitored in the body. Okay, there's inside the blood, there's things called chemoreceptors or chemical receptors. So within the bloodstream, there are receptors that are monitoring all the chemicals in the blood. And one thing that they are monitoring in the blood, they're looking at oxygen levels in the blood, carbon dioxide in the blood, and also the pH content of the blood. So what's going to happen is if something is out of balance, if any of those values are out of balance, sometimes what will happen, that will trigger the brain to influence respiration, because obviously oxygen and CO2 is being controlled when the animal inhales and exhales. So what will happen, what I want you to know for values, well, let me talk about this on the next slide. So the chemical receptors are within the brainstem and then the carotid and the aorta, which are the, you know, the main kind of arterial flow. And those receptors are monitoring these levels. So if I ask you, what do chemical receptors monitor in the blood? For the respiratory system, oxygen, carbon dioxide, and pH. Those 3 values. CO2 probably influences it the most. So carbon dioxide levels are linked to pH. So I'm going to write down the normals that you need to know. So CO2 in the blood should be, and pH is, okay. So in a normal animal, CO2 should be about 40 and pH should be 7.4, okay? If for some reason, say there's too much carbon dioxide in the blood, if CO2 goes to like 45, 50, 55, 60, if CO2 goes up, the chemical receptor picks that up and tells the brain to increase respiration. What happens to CO2 if I breathe more? What happens to CO2 the more I breathe? You blow off more, you get rid of it. So the body is telling me, hey, you got too much CO2, let's pick it up, let's start breathing more. Now, what happens though, before that happens, when CO2 starts to go up in the blood, pH starts to come down. It's kind of trying to buffer the CO2, but what happens is when CO2 goes down, or I'm sorry, when pH goes down below 7.4, is that acidic or alkaline? Alkalytic. A pH below 7.4, it is acidic. Okay, so what's going to happen right now, if I have an animal with a high CO2 and a low pH, that's called respiratory acidosis. Because what's happening is the CO2 goes up, which forces my pH down. They're called inversely proportional. Now, to fix that situation, the brain tries to initiate more ventilation, more often and more deep, to try and get rid of CO2. What should happen if the animal breathes more, CO2 comes back down, pH should go back up. Okay, so they kind of try to balance, but to influence, the main thing I try to get my students to understand in so many classes is to get rid of CO2, you have to breathe more. To breathe, when you breathe more often and you breathe deeper, you're going to get rid of CO2. If you want CO2 to come up, you don't breathe as often. So what happens too, now say there's a bunch of breathing rapidly and the CO2 goes down. Say it goes to like 30 or 25, it drops below 40. Well, when the CO2 goes down, pH goes up and the animal becomes alkalytic, and we have what's called a respiratory alkalosis. Now, we don't want that either. We want to try to keep base. We want to try to keep 7.4. So when this tends to happen, a lot of times during anesthesia, I've been in surgery rotation helping the students, and sometimes when they bag the animal, they like ventilate them like during surgery. Sometimes they get overzealous and they bag 2 or 3 times in a row. Then they look at their CO2 and it's like 22. You know, it's like, they're like, oh, it's low. What do I do? I'm like, stop breathing for them. Back off. What happens is then when you're not breathing for them, and if they don't breathe, that CO2 will come up and it will start to normalize and the pH should come down. So I just want you to know the main thing is that when CO2 goes up, pH goes down. And when CO2 goes down, pH comes up. But if the CO2 is altered up or down, that will influence the respiratory rate. Okay, for example, and it's weird that you guys aren't in front of me, but if we're in class, or maybe you're sitting there and you're just like bored to tears and you're like barely breathing. You're kind of like breathing real shallow, trying not to fall asleep on a Monday. And then all of a sudden you go, you do that sigh out of nowhere, and you really can't predict it. It just kind of all of a sudden you go, well, when you're sitting there not breathing very deep, and if you think about when you're just like chilling, if you think about you're not breathing very deep, but what's happening is when you don't breathe very deep, CO2 levels microscopically are going up. And then to get rid of that CO2, your body triggers a sigh breath. And sometimes after you do that, you pause a minute because you just got rid of a bunch of CO2. And then you get back to your normal rhythmic breathing rate. So that sigh breath that you do periodically, that's your body controlling CO2. Now, the reason that if you work at a clinic or you've been at a clinic or you've seen them in surgery, you see them squeeze the bag every once in a while. When an animal is under the influence of anesthesia, they can't normally sigh themselves because they're respiratory depressed. So we give them a sigh breath to help expand their lungs and to help maintain good CO2. So that is the purpose of the squeeze in the bag every once in a while when they're under anesthesia. Some people in practice, they just go, I don't know, someone I work with told me to squeeze the bag every 5 minutes. Well, now you know why you're doing it. It's to expand the lungs to prevent lung collapse, which is atelectasis. It's also to help blow off some CO2 and help maintain CO2. Yeah, I mean, so you might see your animal all of a sudden do that. It's the same thing. So anytime your animals or we do that sigh breath, it's the body reacting to that internal carbon dioxide level. Now, the other thing, remember I said chemically in the blood, the other thing that we're looking at is oxygen levels. So now it's not as direct as carbon dioxide and pH. Carbon dioxide and pH are pretty sensitive. Oxygen levels can vary, but I want you to know the word hypoxia. Hypoxia is low levels of oxygen. So if for some reason, say our animal was having some respiratory difficulty or had low oxygen, what the body will try to do is signal the animal to breathe more. I mean, if you've ever felt like you can't breathe for a moment and you feel yourself, or, if like say you just ran a mile and you're not used to it and you've used a lot of oxygen, then what's going to happen is the body's going to increase your respiratory rate and your depth to try and bring in as much oxygen as possible, to try and influence that. Now, if an animal has like what I would call slight hypoxia, so when you guys go to the doctor and they put the little thing on your finger, that's your oxygen saturation. It should be 95 to 100 is normal. You know, if we're like 90 to 95, which would be like slight hypoxia, you probably feel maybe a little winded and maybe a little off. Oh, I can't even imagine. Hypoxia can make you feel really funky, really funky. But if the oxygen levels don't improve, think about it this way. The nervous system is trying to like say, get more oxygen, get more oxygen, get more oxygen. If you get to a point where you're severely hypoxic, where the neurons are firing, then what can happen sometimes is they are so overloaded. Think of it like overworked, that the neurons can actually shut down and stop sending impulses to the respiratory muscles, which can have the animal stop breathing. What would the term be when you are trying to take a deep breath but can't? There is pleurisy. Is that what you're thinking about, Catherine? Pleurisy, when you get like a pain in the, like in your chest, and sometimes
Yeah.
they, yes.
I was just curious. Like every now and then, I feel like it's always when I'm sick or something like that. You like have the need to take a deep breath, but you can't like satisfy that need, so you just take like short little breaths until you finally can. I was just curious.
Oh yeah, so like, well, you can get to a point where if you feel like, if you feel crummy, like you have a cold or an upper respiratory infection, um, that can put an influence on how you breathe. Now, if you were to the point where you were sick and literally it was, you weren't able to get oxygen, yeah, then you hopefully your body would try to trigger deeper breaths, because, you know, and yeah, I mean, Alex, numbers like that, like what I talk about in animals, and it's very similar in people. When you're below 85% saturation, that's severe hypoxia. Like, and what can happen when you get numbers like that, you can really plummet fast. And Corona, you know, because it's in the news, and coronavirus, one of the things that they've tried to get doctors to do, and sorry, Catherine, if I'm diverting from what I was saying to you, but what they were trying to do was send people home with little pulse oximeters that go on their finger, because when your oxygen levels fall below 90, that's an indicator you may need oxygen therapy. And if you're below 85%, you may need more intervention. They were talking about proning, which is putting people on their chest, which makes you breathe from the back of your lungs. Because the problem is everybody sleeps on their back. And if you think about it, then your chest, the top of your lungs have all this room to expand, but the back of your lungs are laying down and you're not using those. So this thing that they do in people with COVID before they put them on a ventilator is they do something called proning, and they make them lay on their chest. And what that does is it puts the weight on their chest, but then they can use their lungs. And what they're trying to do is get you to expand all, because, you know, if you have COVID and you can't oxygenate, you need as much lung as possible. And they're forcing you to use parts of your lungs. Like there was exercises they said you should do when this COVID thing was happening. They were like, lay on your couch or lay on your floor on your chest and do these deep breathing exercises. And it was almost like exercising the back of your lungs, so that if for some reason you got COVID, you're recruiting those lungs. So they were having you do this like 2 or 3 times a day. But monitoring oxygen levels, like especially if you, like Catherine was saying, like if you didn't feel good and you were breathing really shallow, if you were breathing shallow and you're like a normal healthy person, you probably don't have hypoxia. Your body will balance it out. If you get to a point where you're dropping into these low numbers, your respiratory system should trigger these deeper breaths, like cause you to breathe deeper. Now, if your chest hurt or your lungs were full of fluid, that would be different. You try to breathe deeper, but you can't get enough oxygen in. You might need like medications to help, if that makes sense. I know I'm saying like a lot of broad things, so if none of that makes sense. But when we get into anesthesia, we talk about normals for oxygen levels, but it's very much in the news with COVID that they were saying if they could get to these people before they came to the hospital gasping for air, then we could have better success. But the only way to do that, if you give them a pulse oximeter on their finger and they could monitor themselves at home, when they hit a certain level, they're like, you got to come into the hospital, because then you're getting, and like severe hypoxia. I mean, sometimes you have animals that come in with severe like the animal comes in and their gums are blue, their tongue is blue, they're gasping for air. They can just stop breathing if it's bad enough. And we want to get to them before that happens. So, that's the PowerPoint. Let me go to this handout though for a second. That was, hang on a second. Hang on. Okay. Okay, so I'm just trying to make this so you can actually read it. Okay, so I sent this, or not sent this to you. This, and I have to get your test submitted so that you see this by tonight to get that get them completed. When blood, what I've talked about, you have to trace blood flow through the heart again for this test, but I want you to expand on it and add what's happening in the lungs. On this last test, all you had to do was put pulmonary artery, lungs, CO2 for O2, which is just the basics of like go to the lungs and get rid of carbon dioxide. But basically when blood is coming back to the heart from the body, it's high in CO2 and it's low in O2, and it's coming into the right side of the heart. So it goes right atrium, tricuspid, right ventricle, pulmonary valve, pulmonary artery. Because when it's going to, and then when it's coming from the lungs and coming back to the heart, it's high in oxygen, low in carbon dioxide. And this gas exchange, which is what I explained in those pictures, is happening at the capillary level and equaling partial pressures. So that's when it diffuses. So this was the same order that should have been on the test. But if you look, let me pick up at where I did. I have right atrium, tricuspid, right ventricle, pulmonary valve, pulmonary artery. Now the difference here is what happens. It's the same thing that happens in the body. It's just you add pulmonary to it. So after pulmonary artery, it goes to a pulmonary arterial, which is a little artery in the pulmonary, in the lungs. And then it's going to go to a pulmonary capillary. And what I've added is the pulmonary capillary is at the alveolus. Okay, so this is one. And at the alveolus, this is where CO2 goes in and oxygen comes into the blood. Then after that capillary, it's going to go to a pulmonary venule, little vein, which joins the pulmonary vein. And the pulmonary veins now have oxygen in them, are going to come into the left atrium through the mitral valve to the left ventricle to the aortic valve, aorta. And you can see in my words here, I started at the aorta. But the only thing I'm adding for this test is just this better description. Instead of just saying lungs, well, what is happening in the lungs? It's like, instead of renal artery, I have pulmonary artery. Instead of renal arterial, I have pulmonary arterial. So I've just, instead of going to an organ outside the body, these are going to the lungs. And like I said, remember, they're flipping it. So I'm going to look at, once the test is submitted, and you can go back in and look at your blood flow and see what you got wrong. And I'll explain now, when you get your score, I believe that question was worth 5 points. If it's all correct, you get 5 points. If you missed a few things out of order, you might get a 4 out of 5. If there's more than one out of order, it might be a 3 out of 5. And then, if it's a 0 out of 5, it's just completely um, out of order. So, but this handout, similar to the blood flow from before, it just says pulmonary circulation. And let me show you this other picture. It says respiratory supplemental. I just want to keep, oh, yeah. Okay, so this was just some pictures that I thought might be helpful. But this is talking about, you see how the trachea, it's going to go to a main bronchus. A main bronchus goes to a whole lung lobe. So one bronchus goes into, and then once the bronchus goes into the lung, it's going to break up into the bronchioles, which are the smaller, you can see these bronchi here. There's the bronchioles, and then this is a picture showing kind of like what it does in your notes, but to see how there's an alveolus and there's the capillaries, and that's where, and you can see here's a pulmonary arteriole, here's a pulmonary venule. Now, this one is actually colored blue. Normally an artery is never blue. They've colored it blue in this picture because when the blood comes to the alveolus, it has high CO2 and low O2. And then you can see a pulmonary venule. Venules are always blue, except they colored it red in this picture because it's representing now it's high in oxygen. So this is just, I don't know, I thought this could be helpful. This talks a little bit about the blood flow. I thought, another picture I found could be helpful. So do you have any questions?